Good afternoon, everyone. I hate to break up the party. It's lovely. It's lovely to hear the chatter in the room. It's very refreshing. So but we're going to start promptly because we only have 2 hours here, and obviously we'll be going off to have afternoon tea as well. So I'm going to start off anyway and do some introductions. So you're all very welcome to this most spectacular house. It's beautiful, isn't it? It's a real treat, and we're very privileged to be here. So I hope you all had a pleasant journey also. This year marks our 8th Metastatic Breast Cancer Awareness Year and Seminar. And now, of course, we're doing webinars as well. So this is a hybrid model today. So just to let you all know that it is being videoed, and to ask if there's anybody in the room who may not want their face in a video, would they let us know? Maybe put their hands up now, or let Jane know, because that would be really important in terms of, you know, using this as a resource following the meeting. Okay. Okay. So our actual theme for today is no borders, no boundaries, and no barriers. Let's talk. And you'll understand why that is as we go through the afternoon. A lot has happened over the last couple of years, and we all acknowledge the difficulties, challenges, but also the opportunities that COVID has given us. It's on our doorsteps. So today we celebrate being together in the room. And I love these meetings. There's lots of chitter chatter. It's like, you know, you've met for the first time and you're wanting to talk about everything that's happening in your lives. And the day is created for us. So we're also sorry to say that Europa Donna cannot be with us today. I want to acknowledge, though, that we have a long-standing partnership and relationship with Fiona and Tara, but we do have Miriam today, so welcome, Miriam. So for those of you who don't know me, my name is Helen Forrestal. I'm Director of Nursing at the Marie Keating Foundation. I'm not going to talk about myself too much, but I do want to say that I have a long-standing history of working in oncology and urology, both in the UK, Ireland, in the private sector and in the community. I do have a passion, as most of us do, working in oncology, to look after people holistically in the best way that we can. I returned to Ireland back in 2006, and I studied my master's AMP in nurse prescribing, but I'm here in the Marie Keating Foundation. My role really has evolved to encompass a patient-centered approach to care, and it's based on the principles of empowerment, dignity, compassion, justice, privacy, confidentiality, choice, advocacy, and quality. And that's why we're all here today. So we'll get the housekeeping out of the way. You've all managed to have a cup of tea, have you, down in the cafe? That's where we'll be going for afternoon tea today as well. Okay, and that's where the toilets are. Unfortunately, there's no toilets in the room in this house. Okay, we're not expecting a fire alarm, but if something happens, we'll have to meet outside. Okay, and if you have phones, I'd probably ask you if you could turn them off, please, or silence them. And just make sure you can hear, because everybody hear and see me and the screen, so that you can hear and see the speakers. And then for people in the virtual space, I welcome you. So make sure you're sitting comfortably and that you can see and hear the screen. You do have a number to ask questions, so I'll be keeping an eye on that as we go through the next couple of hours. And if you do, please do ask questions. We really want you to participate in the afternoon. It is going to be recorded, and it will be available on YouTube channel next week, Jane, isn't that right? Yeah. Okay. So just to get a couple of thank yous out of the way as well, we'd like to thank Pfizer and MSD for their commitment to supporting us to allow this to happen year on year. Thank you. Our expert panel of speakers, and I'll introduce you all individually as we go. I'd like to thank our Marie Keating Foundation staff. Liz Yates here in the audience, our CEO, who's going to speak at the end of the session. We've Linda Keating here, who is our co-founder. I think you all know Linda, and Director of Fundraising. Bernie Carter, who is our Assistant Director of Nursing. We have Fiona, who is at the desk, Fiona Sullivan. So Fiona will have been in contact with you regarding this event anyway. And we have Jane over here in the corner, who is making sure that everything has been captured and recorded today. So thank you all. It really is lovely to have you here supporting me today. And again, I suppose like we will have a pass to the garden afterwards. There was no pass at the desk, but do feel free to go into the garden once we've had afternoon tea. I want to make a special mention to Book Centre and to Sandy, who have provided some really nice gifts for us in our goodie bag, and also to Bravel at the end of the room. So you'll see what's in them later on. That's a secret and a surprise when you get to afternoon tea. Do take the opportunity as well to visit Cushnor, Hope and Solace. They're your local cancer support centres in the area, and they're all here to help and support you. We have Joyce from Wigworld as well, and we also have our own stand with literature and information and Europa Donna. Have I missed anybody there? No? No. I'd also like to pay special mention to our healthcare professionals. Respect and gratitude always to you all, because the effects of COVID are still here, and we know that. I know we're not wearing masks today, but we did say if people wanted to wear masks that they are available. But I guess we've moved out of that space, haven't we? Very quickly, as quickly as we moved into it. But do be mindful of maybe using hand gels as you go today, and mind yourselves, because I know many people are still on treatment. I do want to make a special mention of Daniel, who is the manager here in Mount Congreve. We've had such a warm welcome from all the staff already, and we haven't even had afternoon tea yet. But it's been a special connection too, and I want to make a special mention of Daniel's mother, Shirley. She left this world 2 years ago from a colorectal metastatic cancer. So the conversation Daniel and I had was that we were meant to be here today. And lastly, I want to thank you, ladies and gentlemen in the room, and it's lovely to see some gentlemen in the room, because it is you know, who is making today happen for us. You have been affected by metastatic breast cancer and know only too well what this means for you and for your loved ones. I know you get each other. We see that, you know, when we run our groups, you get each other, but we want you to teach us how to get you. So thank you for that. So I'm not going to talk about the agenda too much, but we're breaking it into 2 sessions. So session 1 is going to be kind of medically orientated, but we do have Catherine, who's going to come and light a candle for us and say a few words. We have Louise, Miriam and Ada going to talk about the holistic approach to care and how it is in the world, you know, out there for metastatic breast cancer patients and their families. And the second half is going to be quite intriguing in the sense that we have Anne and Siobhan, who are now, you know, we know them as patient experts. They definitely are patient experts. But we also know that anybody in the room maybe cannot be a patient expert, but certainly can be a patient advocate. And we're going to hear in conversation what Anne and Siobhan have to say. It'll be mainly around the survey that's happening, around the unmet needs of women in Ireland with metastatic breast cancer. But it will also be learnings from Northern Ireland and what we can take from that and what we can do for each other. No borders, no boundaries, no barriers. Liz will do some closing remarks for us. And we do have Ray Sinnott, who is the man of the house, who's going to give us a nice guided tour from here down to the cafe and tell us all about the house. So that would be really nice to hear. And then anybody wanting a coach pickup, the bus will pick up at 5:30 from here. Okay. So Catherine, I'd like you to come up and say a few words. And thank you, Catherine, for doing this. This is very personal. Catherine is a member of a Positive Living group. Okay.
Today we remember and honour the loved ones who are sadly no longer with us. We remember with great affection the deceased members of the Positive Living group and the Europa Donna group for their tremendous support and friendship. We also wish to acknowledge each other's personal grief within the room, people who've lost family members and friends. I today would like to pay tribute to my own sister, Mary, who died from metastatic breast cancer 2 years ago. We light this candle today to symbolize hope, healing, and remembrance.
Thanks. We'll just take a moment, I think, to remember our own losses in the room, and hope there is healing and hope within. And I'll try and make it hands in there, but I burned my face a couple of years ago, so. Okay, everybody okay? You ready to move on? Okay, so we're getting to the clinical side of things now. And I'd like to introduce Louise Mullen. Louise is the National Lead for Cancer Survivorship within the National Cancer Control Programme in Ireland. Thanks for travelling today, Louise. So Louise has a strategic role which drives implementation of cancer survivorship supports and services nationally for cancer patients and their families. She has worked in the HSE for over 20 years and believes strongly in collaboration and cooperation across many sectors and disciplines. Louise collaborates nationally with many stakeholders, including patients, healthcare professionals, and voluntary agencies to develop and improve the provision of care in this area. And before I call you up, Louise, I'm just going to introduce Miriam and Ada as well. So Dr. Miriam O'Connor is a qualified in University College Cork, and after completing her general medical and medical oncology training, took up her current consultancy position, medical consultant oncologist in University Hospital Waterford, and that was in 2017. The principal cancer type she deals with is breast cancer, so ideal to have Miriam with us today. She is involved in research both locally, nationally and internationally, and she has been involved in medical teaching for many years, and currently is the co-national director of the training programme for medical oncology in Ireland. And then finally in this section, I'd like to introduce Ada Kinneally. So Ada has worked as an oncology nurse for over 20 years, working as a chemotherapy nurse, clinical nurse specialist, and advanced nurse practitioner. And having specialised in oral therapy management and Herceptin clinics, Ada became interested in the psychosocial and lifestyle issues that men and women with advanced and early stage cancers encounter at diagnosis. And she focused her master's dissertation on cancer survivorship. So you're all very welcome. I think Miriam is missing at the moment, is she? Or is Miriam around? Where are you, Miriam? Hi, Miriam. I couldn't see you there. Okay. Not top of the class. Okay, Louise. Yeah.
Thank you, Helen.
Now, there you go, Louise. Thank you so much.
Thank you for that introduction and also for that lovely reflection that we all just had. So I was coming down today to listen and sit in the back of the room, but as you know, Helen and her colleagues are very persuasive, and they asked me to say a few words. So I'm not going to go on for very long, but I'm going to kind of set a scene and talk a little bit about policy and our structures, because I think sometimes that's useful for people to know how we implement things in Ireland. So what I'm going to do is go back a little bit to the 2006 strategy, National Cancer Strategy. This was the second National Cancer Strategy, and in it, there's a lot of talk about survival, but no talk or no words about survivorship or living with cancer. So it's not that long ago that we really didn't have the same conversations that we do now about these two areas. And two things have really happened. The first is really the treatment has improved so much, and the cohort and the group of people who are living with or beyond cancer has grown and grown. And so in the interim between these two strategies, we had an international evaluation report. And so some international experts came from other countries and evaluated our strategy and looked at our what was happening in our cancer services and made a number of suggestions. And one of the key suggestions they made is in terms of this area of living with and beyond cancer or cancer survivorship, and also patient involvement and patient partnership in these areas. So when it came time to frame the 2017 strategy, there was a kind of an imperative from the evaluation to include these two very important areas. And I think so in forming the strategy, the Department of Health is our policy formation unit, and through the Cancer Policy Unit, they had a very high level steering group. And on that steering group was the stakeholders you would imagine that would be on it: healthcare professionals, the health services, representatives from lots of different groups who have interest in cancer. But it's sitting in parallel with that was a patient forum. And this patient forum was a very powerful policy kind of, I guess, lever is the way to say it. Helen Forster was on it, but there were many patients, many representatives from advocacy groups, and it sat in parallel with the steering committee. And the Department of Health chaired both groups. And there was liaison members between the two groups. So the policy was formed over a period of about 6-7 months. And there was also a public consultation that was done where we had, I led that public consultation, and there was 225 submissions to it. And the things that came through very strongly in that, in terms of patient voice and patient partnership, was the need to care for people who are living with cancer and who are in a survivorship period, who have cancer that is largely curable. Other areas were the areas of psycho-oncology, attending to psychosocial needs of patients, and making sure that there was some integration across our cancer services, and also that there would be continued patient involvement and patient partnership in our strategy. So I'm not going to go over all the recommendations. There are 52 in all. In fact, I'm not going to go over any of them, but about a third of them are really pertinent to those 3 or 4 areas. And I think that has given the energy to create my position and other positions within the NCCP. The National Cancer Control Program sits within our health services, and we drive the implementation of this strategy. And liaise quite closely with the Department of Health, and then also the cancer services on the ground, and advocacy organizations and patient organizations and patients themselves. So in the subsequent years, we have had the National Cancer Survivorship Needs Assessment, which was inclusive of both people who are largely cured from cancer, but also people living with cancer, and a psycho-oncology model of care, which focuses, again, very strongly on that need for an integration, recognizes that there's quality of service in the voluntary and community sector, and that we need that to be part of our system and part of our services, and to recognize that quality. And we actually need to increase the number and the capacity of our support services, as well as our actual cancer services. So one of the things that we've done in the last year is we've pulled together something that we call the Alliance in the NCCP. And this is an alliance of community cancer support centers, some of which are represented here today, and also services, including the Marie Keating Foundation and other services as well. And this is, again, most of these organizations are in the voluntary and charity sector, but this is a way that we can support these organizations, endorse them under the umbrella of the National Cancer Control Program, and bring them closer to our contacts in actual clinical services. Make sure that they know about these services, and that they know that sorry, that's my telling me that I'm at 5 minutes. That these services, particularly the community cancer support centers, sign up to our best practice guidance, that we have a self-assessment and peer review process that we go through with the community cancer support centers, and that they become part of our services. We also support them at the moment with a small grant program. We work hard to support them in their bids for funding, but also make the argument that these are crucial de facto community services and that they need to be funded and supported, particularly in recent times where there has been decreases in fundraising and increases in the needs and complexity of people presenting to these services. So I just wanted to let you know about that. And then we also have self-management programs, one of which the Marie Keating Foundation delivers under the Thrive and Survive program, but it is also delivered through the community cancer support centers. And the LACES program is Life and Cancer Enhancing Survivorship. And this is a program that's signposting and information is delivered by oncology nurses at the cancer centers at the end of active treatment. And we worked very hard to make LACES an inclusive program. So it includes people who we would traditionally put under the survivorship umbrella, but also people who are living with cancer. So it has information and signposting for an inclusive cohort. So we work hard thinking about empowering patients, healthcare professionals, and community supports. The patient forum was just for the life that I mentioned before, was just for the lifetime of the strategy formation. But one of the recommendations in the strategy was to form a cancer patient advisory committee. And that is 15 patients who are, again, it's chaired by the Department of Health. They gathered 4 times a year. They discuss the strategy, the implementation of the strategy. They bring people in from services to talk to them about what's happening, what could happen better. And they exercise that lived experience voice. So I'm not a member, but I sit as a liaison so that when they have questions or they need to bring somebody close, I bring that person in for them. We have patient and healthcare professional members of all our key governance groups in the NCCP. And again, I mentioned the Alliance, the networking events. We have healthcare professional forums, particularly my nursing colleagues bring their nursing colleagues together quite frequently to discuss any kind of new innovations or sports and services, listen to them, but also to try to create things internally. And then we have professional audit, quality, and research days. So just a little bit about the future focus. Obviously, in a short talk, I can't talk too detailed about this, but I'm interested in the results and the consideration of current needs assessments. You're going to hear of 2 pieces of work done here today, but there's a 1 or 2 others that are also very pertinent to this area. We're very interested as a next step to look at the practice in cancer centers. So we're hearing a lot of, anecdotally what's happening, but what we often do is we kind of look under the hood. And what we generally find is that there's a lot of variation in service and variation in practice among our 8 cancer centers. But that's a piece of work that needs to be done in probably the next year. And but by doing that, we'll be able to identify best practice nationally, and then also look at the international evidence base, and then we'll look at where the gaps are. So I think it goes without saying that we'll need to build and link supports and services. I mean, that's what we're going to find, but maybe we'll have signposting to what will be our key priorities in that. And then I can't but say that we need to think about strategic recommendations for the next strategy. They're very powerful in driving our work, and there isn't always money, as you've seen in the last budget, or this budget, but sometimes there is, and when there is, the strategic work that we do and these plans that we have and these recommendations are in the strategy is what gets funded. So thank you for listening, and now it's my turn to listen. And thanks again.
Now, the lady at the back of the room.
Time to show my face. Okay. Yeah, afternoon, everybody. How nice to escape from UHW. And how nice that the sun has come out in the sunny southeast. I definitely have been an advocate in our family as a tourist promoter for the sunny southeast. And today you can see it. I hope as many of you as possible do take a trip around the gardens. They are magnificent. You'll hear about when is the best time to come. Any time to come to Mount Congreve is a pleasure. I've been out here. It's an absolute pleasure to be in a room that I'd never been in before. So thanks very much. Thanks to the Marie Keating Foundation for inviting me to talk. So my brief was pretty wide and my time is pretty short. So I hope there's something in what I'm going to say for everybody, but there will be a lot that I won't mention. There will be people who will say, well, my bit wasn't mentioned, or why didn't you say this? It's very difficult to touch on something for everybody, but let's see how it goes. Please give us feedback afterwards and let us know if we hit the spot or not. And I suppose today is a very auspicious day. October is well known for being Breast Cancer Month, but today is actually Metastatic Breast Cancer Day worldwide. A lot of work went into getting one day out of the 365 dedicated to one disease. So today is a very important day for lots of reasons, for lots of people. And that's why it's a real pleasure to be here to help with the advocacy that's needed around metastatic breast cancer. There was a slight typo for those of you in the room who know me longer than 7 years. My bio, obviously, I forgot about the other 10 years I was here before 2017. So I am the youngest doctor around. Okay. So what I'm going to touch on is MBC and its various different faces. I thought this picture might capture it. I really think it's like having a big heavy backpack on. Sometimes there's people along the way that help you carry it. Sometimes you feel like you're on your own. I'll talk about guidelines. I'll do a little bit about what's new. I'm going to talk a little bit, or I hope by the end of it, you'll see why every one of you might be on, who's living with MBC, maybe on something different to somebody else. And then I'm going to talk a little bit about my approach. I'm not touting for business, okay, but I'll talk about my approach. Okay, so I live in a black and white world with lots of shades of grey. These are a whole variety of scans of different parts of their body. And MBC has lots of different looks, and that's the first big thing. I don't think there are any two people at MBC who have the same problems. There are lots of common problems, but there are lots of very unique. Each individual is different. Now, what I much prefer is to put in this picture. And this is with the express permission of myself in the blue funny Santa Christmas top and Avril. So I rang Avril the other day and I said, Avril, do you want to be famous? So Avril was delighted to take the call and say yes. So Avril has MBC, and Avril and I meet in the clinic, and then we meet at various different local races. And the goal is that she beats me most times. I do take pleasure every so often in getting there before her to the finish line, but the goal is that she beats me. So this was the two of us last year at the Waterford Half Marathon. So we meet again in 2 weeks' time at the Dublin City Marathon. So this is achievable. No, okay, I'm not saying go out and run a marathon. But what I am saying is there are so many different faces. You know, there was a time that Avril would never have thought of running 10K, not to talk of a half marathon or a marathon. She has fundraised extensively as a result of her events. It's become a family. It's become a whole community effort, and she continues to do it. So thanks, Avril. So as well as the faces, it has a couple of names. And I often say to people, anything in medicine that has a few names means nobody likes the name. Like, let's face it, metastatic breast cancer, I think, is quite a scary name. I don't know. I know in my world, I'm used to that word, but I think it's a scary word. Secondary breast cancer doesn't sound much better. Stage 4 disease terrifies the life out of people. I can talk to people about metastatic breast cancer, and I'll talk about advanced breast cancer, and I'll talk about, and they'll say to me, yeah, it's here and it's here, it's here. And we'll talk about all of that. And then somebody will say, so what stage is it? And I'll go, well, we've touched on where it is, and I'll say stage 4, and it's a conversation stopper. It's a total shock. So I'll often say to people at the beginning, this has 4 names. Which name will we go with? Now, I go to a meeting in Lisbon every couple of years. I haven't been for a few years now with COVID, but it's a meeting I'm going to refer to. And it's an international collaboration, but thankfully it's based in Europe. And the name that they selected was ABC, Advanced Breast Cancer. And I like that. It's nice to shorten something to I have ABC. People don't tend to go, oh, you have ABC. Whereas if you say you've stage 4 something, people go, am I right? Yeah. Okay. Yeah. Okay. So, so they're the different faces, they're the different names. And I suppose I see people who've had a previous breast cancer in the weeks, months, or years, or many, many years. And I also see people with MBC that's their very first time coming in the door. And just in that alone, there are different needs. So I see people who, and that particular type has a name, because let's face it, everything has to have a name, and let's make it a name that sounds odd. De novo, you know, I don't know whether that sounds like some kind of fancy car, but the words that come after it are still MBC. In terms of treatment, I suppose a lot depends on this language of hormone driven, hormone positive, HER2 driven, HER2 positive, triple negative. Medicine and our language is funny. Sometimes something positive is actually not a good thing. True? Yeah, okay, great. Sometimes something negative is a good thing. So, you know, so our English words in medicine can mean different things. So if somebody's banding about these words, say, what do you mean? So as recently as yesterday, I talked to somebody about their cancer that was hormone positive and HER2 positive. And at the end of the consultation, they came back and they said to me, somebody said I had triple positive breast cancer. Is that a separate cancer? You've not mentioned that. So it takes a while to learn these things, and it's like learning a whole new language. So I'm sorry that it's so difficult. And when it gets onto the names of drugs, that even gets more difficult. I have difficulty pronouncing some of them. But basically we talk about it being some kind of a mixture of having these hormones, having HER2, having them or not having them. And those, we get that information from the pathologists. So there are people who with MBC in the room here, there are people you'll never meet. They're the people that look down the microscope and the people who look at scans. They're named, well, they're not nameless, but they're faceless to ye, but they give me pieces of information that then I try and interpret and explain in layman's English. I get these terms from the pathologist. Now, when I see somebody with MBC, I want to know what type it is, and then I want to know where is it, and then I nearly have enough to start getting going. Guidelines. So guidelines are there to support me in what I do, to ensure a standard. I think there are a lot of us who would say a guideline is a minimum standard. So it's not necessarily a maximum standard. If you're working to a guideline, it's not necessarily that's great on one level, but we would like to aspire to working beyond the guideline. There are lots of guidelines for MBC. I really like this ABC. Let's go from MBC to ABC. So ABC was an international collaboration, Americans right across multiple European countries, Australia, New Zealand, lots of different national and international cancer organizations, both from a surgery, radiation, and a drug perspective. And they started a number of years ago with ABC1 in Lisbon. And in a few weeks' time is the 7th consensus. I really like the meeting. It's a 2-day meeting. The first day, there are a lot of patient forum meetings, patient advocacy, patient forum meetings. And then like they spend about 2 years reviewing all the new literature. And then there's various topics selected out on the basis of the advances from a medical or from a physician perspective and from a patient perspective. And then there's a day and a half. So the first day is a lot of patient specific forum groups. The second half of the first day and the second day then are particular topics that are selected out for discussion. And then the last morning is the 45 panelists that have been reviewing data for 2 years up on a stage, and they go through the 50 questions. Are we changing this recommendation from 2 years ago? Are we changing this one? There are high-income countries, medium-income countries, and low-income countries, because, you know, there are some societies where you can have access to everything. There are many societies represented in this group that don't have access. They might have access to the hormones like tamoxifen, but they may not have access to a drug like Herceptin. Hands up, who's heard of a drug called Herceptin? Okay, great. Okay. It's incredible how many people know that name, but it's fantastic. It is a great drug. So that meeting is on in a few weeks' time. There are the American guidelines, there are the Australian, New Zealand guidelines, but when you take them out, they're all very similar. And the reason they're all very similar in terms of their principles and practices, MBC is the same when you have it here in Ireland and Waterford as it is when you live in New York, when you live in India, when you live in Sydney. So it's the same disease. What's different is often your access to care. So our Irish, there isn't such an Irish guideline from MBC, because those of us who work in it, we operate to the ABC guidelines, the European, or to the ASCO guidelines. And those guidelines are live. So when major studies come out saying drug B is now better than drug A, there's an update. So they're not static, they're continually moving. So I just thought I'd show you a picture of what some of them look like. There are these complex diagrams, flow diagrams of all of this here relates to the first set of drugs for somebody. So that's the first step on the ladder. So there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 different choices for the first step for one of the types of secondary for MBC. So you're already into why is it different? It needs to be different because most people would, we're not all clones. Everybody's different. And there has to be leeway within those guidelines, even for the commonest type, which is the hormone-driven one, to include all of the different options we have. Here's the first line recommended or suggested guidelines for people who've got HER2-driven breast MBC. So it's not HER2 and you go on number 1. We've got lots of options. And what we do when we meet somebody, okay, we recognize MBC, what type, where is it? And then we go, okay, that's only one part. But now there's the person. So what are the needs of that person? And how do we match the drugs with the needs? How do we make sure that I don't upset somebody's diabetes, chronic obstructive airways disease, they have peripheral neuropathy from diabetes? How do I incorporate the treatment of a new condition along with everything else that somebody might be taking? A third main subgroup then is triple negative. And again, I've got first and second line here. So lots, I suppose what I want you to see is it's great that we've got all these boxes. There are some other diseases or other cancer types where there's a name, there's a drop down to one box. Breast cancer, one of the good things, unfortunately, about it being common is we can study it. We have been studying it. There've been years of trials and lots of women. Oh, hands up, who's ever participated in a clinical study? Oh, okay. Oh, I'm disappointed to see so few hands, because when I ask that question, there's often a lot more hands. So that's one of the unmet needs for us and for you, is more studies. Okay, the guidelines, these ABC guidelines that I talk about, it's not just the types of cancer. There are guidelines about various different symptoms. So there's a guideline for pain, managing menopausal symptoms, which when you listen to Joe Duffy last year would suggest that nobody's read them. Pain, nausea, vomiting, headaches, fatigue. So we have guidelines on how to manage and how to assess all of these. So often if you're with somebody and they're saying, how are you? I often say to people, when somebody in the team with me asks you, how are you? It isn't necessarily just, hi, Mary, how are you doing? We actually are asking, how are you? That's our assessment. And then we want you to give us your words so that we can go, okay, so you've got this. And I'm afraid the minute you tell us you've got this, if you don't volunteer a lot more, then we'll ask you more so that then we can assess it and see how do we manage it. In terms of what's new, I have a couple of slides on what's new. In terms of drugs, the good news is those drop-down boxes about what's first and second and third and fourth and fifth and sixth and seventh and eighth and ninth line of treatment, they get bigger and bigger every year. Every year there's something new. So up on the right-hand side there is a study that I was the Irish lead on in NBC, looking at a hormone type and a new drug with it that got published a number of years ago. It was a really positive study. One of the benefits of working in clinical trials and working with Cancer Trials Ireland is that we have these studies for, sorry, I don't know where else you're from, but I'm really proud to have the studies here in the Southeast for patients here. But all of you who are in any of the other cancer centres, they've got studies too. And breast cancer, we don't treat it all as one because we've got so many different subtypes. So we've got lots of studies, but we never have enough. So we aspire to get up to 10% of people on studies, and that would be really good. So there's always trying to match the study with the person, with the drug, with the disease. In terms of how new drugs become available, whatever subtype it is, they're through clinical studies. So a small little unashamed plug. If any of your doctors ask you about a study, would you be interested? Please say, give it to me and let me really have a look at it. I'm not telling you to go on it or suggesting you go on it, but please say yes. So there have been times where I've had a study and somebody's looked at, and all I want is people to look at it, and if it's not for them, that's not a problem. But it's difficult when at one point I have a study, and maybe at a different point when somebody is thinking, maybe I should try a study, I may not have something at a later point. So we don't have a study for every group at every step along the way. But if one has been offered, certainly consider it. Studies are not just about drugs. The advances in surgical techniques, the advances in radiation techniques have all come from various different studies. And just as recent as last week, the picture isn't big enough because he's in Galway, and anyway, but I will promote him, Michael Kern. He's a professor of breast surgery in Galway. So he was off. Anybody in his clinics is wondering where he was. Anyway, he was off in the States in the last 2 weeks, signing a research agreement with a number of US universities. So that's going to be a tremendous collaboration, flow of ideas, opportunities for trainees, ultimately leading into improvements for me down here in Waterford. Can't stand here and not plug. Does anybody recognize anybody in this picture? We're going to hear about this one in a little while. We're going to hear about this new survey to explore the experience of breast cancer patients shortly. And then, of course, what everybody loves, and any time there's a magic bullet, my uncle, who's deceased now, but for many years, and particularly after I started working in cancer, every time I went home, he would have the cutouts from the Irish Independent, the Irish Times, the Farmers Journal, on the latest magic bullet. And he'd ensure I was up to date. I never really had the heart to tell him that actually I'd heard of those magic bullets. I suppose there isn't one magic bullet. We'd all like a magic bullet, but there isn't one magic bullet, because this is not one disease. This is multiple diseases. And as the journey continues, the disease changes as well. So there isn't a magic bullet. So if I've upset anybody in the room, I'm sorry. But we look for the magic bullet all the time. So you see, when this came out, so what does it say? Magic bullet now available on clinical trial to breast cancer patients in Ireland. So that was last year. Now things have moved on, that's available to a subset of women with breast cancer, with a subset type of breast cancer, and it's actually no longer on trial. We have it available. So you look at that and you go, why am I on that magic bullet? But you know, it's not just breast cancer. So, or it's not just all breast cancer. What else is improving? Well, it's clear that as the group of people with MBC has increased, there's a growing awareness that this is a very specific problem that people have very specific needs in. And a piece of work that I did a number of years ago with an MEP from Deirdre from Cork, Deirdre Clune, who was trying to do some work in the European Parliament, looking at the rights of people who are living with cancer, in terms of trying to ensure employment rights, pension rights, promotion rights, that you couldn't be excluded from things because you're living with cancer, and the need to take time off from time to time, that you would still have access rights. So there's a lot of awareness, thankfully, as people are living with and living beyond their MBC. We're going to hear about a study to address them from an Irish perspective. And I suppose it's been clear for a number of years that MBC needs a voice of its own. And today is that day. Now I'm going to I better move on, or I'm going to take from Ada's. So this was an initiative I was involved in a number of years ago that works with the ABC group in Lisbon. And it's a global alliance where Pfizer one of the companies undertook a study where they invited women across the world who were living with MBC to give their opinion about what worked well for them, what was missing from their care, and what would they like. And out of that came a call to action. So this picture is very small because that's 10 years ago. I obviously look a lot more mature now. So what other initiatives are out there? Obviously, from a national perspective, we have Marie Keating, we have the Irish Cancer Society, we've a lot of information. Information is key, but sometimes when you're looking for your relative, your story, it's hard to find it. You might find, okay, why am I only a half a page in this booklet of 60 pages? But over time, you realize on the journey, actually, a lot of information on the other pages is helpful. International, and I know you've talked about Europa Donna and the ABC. I have to plug the ABC group. Okay, so we're on to the last few bits for me. When I meet somebody for the first time, I suppose the bridge survey at the first ABC meeting was really enlightening. This was an international collaboration for patients to again put in what it's like. 80% feeling scared, 66% feeling confused, 66% feeling depressed, over half of them feeling angry and alone. 98% received enough emotional support from their inner family, which is brilliant, but 38% had anxiety about being open with it. And I can tell you, I recognize that because so many people would tell me, God, the minute you say X, you see people and the head goes to the side, and how difficult that is. 75% of people, and this is over 10 years ago, wanted contact with other people with MBC. Over half of the patients at that time felt that there was too little consideration, that it was higher in countries where there were resources. Okay, so when I meet somebody for the first time, keeping all of that in mind and my experience, my first question is, are they known to me? As in, has somebody been coming to me, or had I seen them in the past for an earlier stage of cancer? Or is this my very first time? So if I know them, then I'd like to think that there's some relationship already. If it's somebody that I'm meeting for the first time, I'm thinking and planning and hoping it'll be a relationship that'll build for many years. So I'm thinking of that. So probably the first time you meet me is the longest one. And then you realize, actually, God, she's not that nice. The next time I met her, she only gave me 10 minutes. Like, I know what medical oncology is because I'm at it over 20 years. But I take time and explain to people, medical oncology is drug treatment for cancer. And I know that that's hard to take on board, because I invariably get asked then about, tell me about when I'll have my radiation and what will it be like. So unfortunately in the hospitals, we are very specialized. So that's why I say, okay, I'm a drug pusher. That's what I do. I do, like, this is very serious, but I do think trying to lighten it and trying to make it, it's not, none of it makes it okay, but just trying to go, okay, I want to create a sense of that I'm part of a team. This is what we do. You're new, and it's going to take you a while to get to know us. I acknowledge at the very outset, and I'll often spend 10 or 15 minutes the very first time before I'll mention any drug, talking about the supportive services that are there. Because I know if I start talking about the drugs and I come back to the supportive services, people are so busy thinking, did she say 3 weeks, 2 weeks? What the hell is a port? Oh, so I like to talk about the support services. I encourage people to use them. I always find it interesting. There are some people who are very slow to use them because I'm not sick. And I say to them, you don't have to be sick to, a Kushner and hope and solace. You don't have to be sick to go in your door, do you? Okay, great. Yeah, that's what I say too. The diagnosis is enough to go in the door. So there's a perception, well, I'm not sick. What would they have? I am a little bit jealous when I go into solace and I feel the air of calm in there. I go, this is unfair. People come into hospitals where it's intimidating, it's cold, it's miserable. You're waiting in a long clinic, I'm running late. And then you go into solace and it's like, oh, come on in. It's lovely. It's relaxing. I'm like, I'm going back to the hospital, because either maybe I need to move and work in solace. I talk about information being important. I talk about it being overpowering. I talk about it being confusing. And I'll often meet somebody on the first time and there's a million questions, or well, no, there's 10 questions. Sorry, I shouldn't exaggerate. And we'll answer all 10 questions, and I could be answering the same questions for a few years. So I'll answer and I'll often find I'll answer a question, I haven't even finished an answer, and there's another question, because there's so much to ask, but it's hard to take it in. And I suppose people's need, so I'm talking about the first time, but the questions and the challenges, and I think people's voice changes. I think people's voice can be very strong at the beginning. It can dim a bit. It can come a bit. I think it can be very weak and timid at the beginning. Then it gets a bit strong. Then it dips. It goes up and down. And that's MBC, isn't it? Yeah, thank you. So I'll talk about principles. This is all in the first visit. I'll talk about what is it. I will mention the different names. I will say to somebody, you know, do you want me to beat around the bush? Do you want me to be fluffy? Or do you want me to give it, you know, to call it? And most people say, tell it to me as it is. And then at the end, they'll often say, well, we were told you were direct. And I go, oh, well, you did ask me. So where is it? I'll talk, the words I'll use are treatable. I'll talk about drugs. I'll talk about how we'll monitor the cancer, how we'll monitor the drugs for side effects. And Ada's going to spend a lot of time talking about that. And I'll talk about quality with the drugs, that it's not just about treating the cancer, it's about taking care of all of you. I'll talk about this closed line of treatments. So I'll talk about first line treatment, the first set of drugs we'll use, and then we've got other drugs, second line, third line, fourth line, and on it goes. Does that ring a bell for people? Okay, great. I'll talk about that there are certainties. If you have MBC, that's a certainty. A certainty is that there'll be drugs. A certainty is that it's a roller coaster. The uncertainties are how long a drug is going to work, whether it'll suit you. There are lots of uncertainties. So, that's I suppose the journey. There are lots of different chapters in the journey. There are lots of different conversations. So my conversation on day one is definitely different to somebody that the first scan a few months on shows it's working. The questions are out the door. I've no questions today. Woohoo! The needs or the questions a year or 2 years later when the drug isn't working is a different conversation. The needs when it's 5 years, 15 years, and there's a problem. So the conversation varies. The person who has a bone problem, the conversation there is different to the person who has a lung problem, who has a liver problem, who has a brain problem, is different to the person who has a lung, liver, bone problem. So there is no one size. We have tremendous guidelines, which are great, but I think the art is, there's a patient, there isn't a patient, there's a person in front of me who has a whole life, and now this damn MBC has appeared. And for me, it's about how do I take those guidelines and apply it to not just the cancer, but to the person. Because I do like to think, now you mightn't always think it, but I do like to think what we do, be it a radiation, etc., orthopedic, whatever, is that there's only one person that we're really concerned about, and that's the person with MBC. Mightn't always feel like it as you trip around to meet all these people. So in Waterford, so I'm one of the medical oncologists. There's a nursing team, you're going to hear from Ada. But from a nursing perspective, at one point, it might be the medical oncology nurse that's your lead. It might be a breast nurse. It might be a radiation lead. We have liaison psychiatry. We're really delighted with the rollout of the psycho-oncology. We now have psychology, AMP nurses, as well as liaison psychiatry. We've a lot of support for people because there's a lot of distress. There's a lot of financial worries. There's a lot of very practical worries, and we just don't have enough social workers. Then at various different points in the journey, like often at the beginning of a journey, it's a total, it's overloading. You might have an orthopedic person involved, a radiation involved, medical oncology, people having scans, a chest physician, and like we all talk the same language, but when we come to the bedside, if we use a different word, it throws everybody out. Or you might just have one specialist, but along the journey, other people come in. So my last slide. This MBC is a journey, and it's a scary journey. It's an absolute roller coaster of a journey. And that is the first certainty. A certainty, or the certainty is, I would like to think that everybody involved in your journey wants to do the very best for you. Mightn't always feel like that when you get sick with the drugs we give you. The uncertainties is when it's calm, like that long road in front of you, how long is it going to stay calm? When it's all over the place, how long before you get a calm spot? So certainties, uncertainties are part of life when you're on a journey with MBC. It's treatable, with expanding treatment options, but the art is trying to tailor for each person, for each chapter. And that's as important as the specifics of that. I thank you.
Thank you, Miriam. Our mission is to make cancer less frightening by enlightening, within the Marie Keating Foundation. And you've done that today. So scary as it is, it makes it less frightening. Thank you. Over to Ada. Welcome, Ada.
Thank you. Hello, everybody. Ada is my name, and thank you to the Marie Keating Foundation for an opportunity to meet you all today. I have been nursing in cancer care since 2003. And the conversations that I would have had with women with metastatic breast cancer is certainly a lot different from then to where they are now. And I suppose my focus when meeting people with metastatic disease has changed from quality to a more of an energy behind it. And I suppose we've shifted towards a conversation around a terminal illness to that of a chronic illness. And I suppose I want to talk to you, I suppose, again, and remind you then of the survivorship care, the health promotion, and the lifestyle things that are important for somebody living with a chronic illness. Today's theme is ideal for nursing because we encounter borders, boundaries, barriers every day in the health service. But the important thing to let you know is that in nursing and in all the healthcare professionals, we don't allow that to get in our way. Sorry, we're just missing it. We're 2 slides there now. I suppose what I wanted to get across today is that the role of nursing in the multidisciplinary team for those living with an advanced disease is that we are there to support, navigate, and coordinate your journey, to take that work away from you and to support you on that journey. We'll coordinate the appointments, signpost you to the different services, follow up on tests and referrals. So we're always there in the background working. But when nursing as well, you tend to build up a relationship with that person, that therapeutic relationship and that continuity of care. So it's like Miriam was saying in her presentation, sometimes questions are important at certain times. With that continuity of care, with that relationship with a named nurse, be it a breast care nurse, or be it your oncology or chemo nurse, that conversation can continue. So it's important to have that point of care, that point of contact. I suppose we want to support you to live well on treatment, because if you're tolerating your treatment, if you're able to manage the side effects that come with it, then hopefully you can live well for a long time on these drugs. Because these drugs do work, but it's important that you can feel well and live well on them. So in doing that, we want to empower you, empower the person and the family on treatment. So that's through good, informed decision-making. As you can see, Miriam gave you various schemas of the various treatments that are out there, and often you have to make a choice between one or the other. There's not just one choice in all of this. Sometimes you're given a choice as to what you have, and I'm sure you've been in that situation. Our role is to help you to make a good decision for you, that it's informed, that we clarify that what has been discussed with you, that we answer any questions that you might have, that we signpost you and give you the information you need to have that type of information. Again, to understand your treatment plan. Often the questions that come back to us is in around, how long will I be on this treatment for? When will my next restaging scans be? What other kind of considerations are associated with the treatment? So again, it's important that communication piece, that continuity of care, that we're constantly having that conversation with you, that you understand where either the end point is with treatment or for how long we stay on treatment. Often I find that people have a perception that there is an end point with their treatment, but often we would go back and clarify that this is going to be lifelong treatment as long as it's working for you and as long as you're tolerating it. Other considerations are in around, I suppose, risks associated with being on treatment. And again, having that therapeutic relationship, having that continuity of care and conversation is important. I put these up on the slides, not to frighten people, but I suppose just again, to empower people. Awareness is key. Things like blood clots. Those with a cancer diagnosis, those on treatment are at high risk of developing a blood clot. And it's important that we as nurses don't just tell you that at the beginning, that we continue that conversation throughout your journey. Because again, it's early recognition, often self-recognition is key for some of these issues. in the same way that infection will carry along when you're immunocompromised. And then other things like skeletal related events, your treatment, your disease, and how it affects your bones. Living well on treatment probably all plays around as well about preventing side effects. And side effects can be prevented and managed well if you know how to. So again, it's around the education piece, the self-management piece. It doesn't always have to be medication. We can share with you tips and tricks and anecdotal evidence that we've learned from other patients as to what works well to prevent side effects. But also giving you the tools to manage your side effects appropriately, have a reference point to see what do I need to take when and how, but also more importantly, knowing when to seek advice. So again, the NCCP have been instrumental in the establishment of an acute oncology service, which came out of oncology. Before, it was quite ad hoc. If you had issues with side effects or symptoms that you were worried about, you could be ringing your liaison nurse, you could be ringing your GP, the chemo day unit, you could be ringing your breast care nurse, and inadvertently none of us answer the phone because everybody is so busy going. At least now there is a new service called the acute oncology service where you can ring into a dedicated number and you get through to a CNS, a clinical nurse specialist, who's able to assess you over the phone, maybe liaise and signpost you to the right service, manage your issues over the phone, and at all costs try to avoid a hospital admission. Also, that your oncology liaison nurse that you might meet in the clinics. Again, if you're worried, you have that point of contact where they can then go and liaise with the consultant and advocate on your behalf. From a service perspective, I suppose we also feel it's very important to involve family members in your care. That second pair of ears is always really important when we're educating around side effects, treatment plans, when scans, when blood test appointments are happening. Write everything down. Come in with your questions written down. Again, early recognition of side effects is key to living well on treatment. Again, there's no point in having treatment that works really well if you can't tolerate it. Often people are a little bit reluctant, a little bit afraid to divulge if they're having an issue or a side effect on treatment because they're afraid that one, we're going to stop it or that we're going to reduce the dose down. But again, that goes back to that first piece around understanding. If we can help you to learn why it's so important to tell us when there's an issue, we can then try and keep you well and on treatment for a long time. Guidelines and standardized care has come through as a theme today. And again, when nurses and doctors are assessing for side effects and how to appropriately manage them, we use evidence-based assessment tools and triage tools, I suppose, to objectively grade a side effect so that we can then apply the most appropriate treatment or medication to that. Living with a chronic disease, I suppose, brings you to the hospital a lot of engagement with hospital services. And again, we can try to minimize that for you. So being a bit creative and innovative in our approach to your care. So to avoid as much hospital appointments as possible, we can use various services like the community intervention team. We can use home nurse services who will come into your home and do assessments like blood tests and blood pressures and weights, and then report back into the hospital. COVID has taught us to be clever as well in our approach. We don't always need to see a person in the hospital. Telephone clinics have become, I suppose, a standard of care now as well. So we've applied that in a blended approach. So we try to bring you into hospital maybe for one visit, and then if well, we'll do the next one as a telephone with that promise that we can bring you back if needs be. Things like the use of central venous access devices. If you're having trouble with blood tests or needing lots of blood tests or it's difficult to get veins, again, nursing can recognize, again, assess. We have all these assessment tools that sometimes the use of these devices can be really helpful just to minimize stress and distress, but also appointments in the hospital. We're in a new era, I suppose, of care with metastatic breast cancer. And as mentioned, I work in the area of cancer survivorship. When I was working as a clinical nurse specialist, I ran oral therapy clinics and Herceptin clinics. And I suppose what I learned from those clinics is that really the treatment related issues were not as important as actually what was going on in life. The impact that the cancer diagnosis had on the person, on the family, on work, on finances, on body image, on well-being. And I became very interested in this. I had no word for it. I just found it very, very interesting, and I wanted to help. And then I started to learn about cancer survivorship care, and cancer survivorship care as a whole is relatively new. It was born in the US. The first real standardized document was in 2005. And as Louise mentioned, in the third strategy since 2017, the concept of cancer survivorship as a model of care, a principle of care, is new. But the guidelines that started off initially around survivorship for early stage cancers are now applicable to those living with metastatic breast cancer too. And the principles of cancer survivorship care, you can probably relate to this from your own experience, is it's all around surveillance for cancer spread and recurrence, early surveillance, early detection. Monitoring for the long-term effects of cancer, not just physical, but also psychosocial. Prevention and detection of late effects of cancer in therapy. So as Miriam mentioned, we have multiple lines of treatment, wonderful treatments, but they can impact on other systems. So some chemotherapy drugs, some endocrine therapy drugs, hormonal drugs, they can affect your heart health. They can affect your bone health. They can develop, you can develop other cancers as a consequence of the treatment you've been on. Some people can develop diabetes and thyroid dysfunction. So again, we have a responsibility to monitor and prevent these issues from happening. And then to coordinate the care between the primary care providers and specialists to ensure that all your health needs are met. So like that, it may be an orthopedic consultant, it may be a diabetic consultant, that we're coordinating that care between the GP, the primary care and the specialist services. But also to come back to the principles of health promotion and healthy lifestyle. I just wanted to put this up here, I suppose, again, as a reminder that we live with risks in our life all the time. One of those is that living with a cancer diagnosis, being on cancer treatment, can cause blood clots. Up to 1 in 5 people with cancer can develop a blood clot. This is known as cancer-associated thrombosis. Outside of cancer itself, it's actually the leading cause of mortality after cancer. So again, education, awareness, empowerment is key. You probably have been informed about it. If not, there's good resources to be that are available to you. And again, having that point of contact if you're concerned. Now, I am missing 1 or 2 slides. So there's other things I wanted to cover. And again, one was in particular to exercise. Okay. Here we are. Yeah, they're a little bit jumbled up. Okay. Excellent. We'll come back to it. We'll come back to it. I'm sorry, the slides have just jumped a little bit all over the place. So Miriam mentioned as well about cancer-related distress, the distress that's associated with your disease. And again, I suppose it's like anything. You know, if you've had a distressing event, you're going to have an emotional response. And we are aware that this can be on a continuum of severity. Anything from a very mild response to a very severe response. Nobody is the same. Everybody has a different emotive response. It can be a normal response. That's the important thing to remember. It may be just that you need to release this in order to accept and move on. But what's important is that if you can't move on from it, often just talking, having someone to talk to acknowledge what you're going through is normal, is expected. And it doesn't have to be from bad news. It could be something as simple as a setback, a delay in your treatment, a dose reduction, something in your life has been disappointing other than your cancer diagnosis. And again, the NCCP within the cancer strategy has developed a model for psycho-oncology care, where we acknowledge the psychological impact of cancer on a person. And I'm very lucky here today. We have Jennifer, our principal psychologist from UHW, in the audience. What I have here on screen is a model of psycho-oncology care. So again, it's trying to standardize the approach to care for patients with cancer. So you can see there, it's all around distress, and it ranges from 1 down to 5. 1 to 2 being mild, adaptive, requiring maybe somebody to talk to, referral to a support centre, information and education, ranging right up to a persistent issue that is unsettling and having a significant impact on your life. And this is what we use to signpost and refer you to the appropriate services. So to do that, I suppose at the first instance, again, it's around empowerment, recognizing that this distress, these issues are normal, and that you can learn how to manage them. So the Marie Keating Positive Living, some of you have been involved in it, the LACES program, the Survive and Thrive program, all touch on that psychological response to events, to a diagnosis, and learning how to manage that and recognize that. The local cancer support centres, again, are not just counselling. I say that every day in my clinic. Solace does not equal counselling. You don't always need counselling. Again, it's around support, self-care, maybe cognitive behaviour therapy techniques, touch therapies, and being part of a support group is what you need. The NCCP has ruled out that all 8 cancer centres now have a psycho-oncology MDT. So here in Waterford, I think we've just become fully resourced in that we have a clinical nurse specialist who would manage those kind of mild 1 to 2 levels of distress through just talking, signposting, CBT techniques, right up to the referral to a psychologist, to a social worker, or perhaps to liaison psychiatry or an advanced nurse practitioner who can manage those complex, persistent issues of anxiety, depression, or distress. Certainly podcasts. I know Helen has done some podcasting through the Marie Keating Foundation. Again, some of our oncology nursing colleagues have set up the Answers for Cancers podcast and the American podcast breastcancer.org. Really valuable tools to inform yourself as to how to support you on your journey or a loved one. I'm just going to get back to... Again, navigating the journey for you. This image again is probably something you can relate to. You're on a journey, it's going straight for a little while, and then there's lefts and rights and forks in the road. And it's not just all around the cancer, around the treatment. It can be around work, relationships, managing family life, maybe difficulty with kids at home, role dynamics within your relationship, genetics, frailty, maybe lymphedema. It's just endless, the list that I could put up there. But again, it comes back to that nursing support. We mightn't always have the answers for you, but we often know where to get them. So having that point of contact, that nurse that you can link in with, and they will navigate you and often refer you to the right service. Coming back to evidence-based care, the survivorship principles that I mentioned a few minutes ago are evidence-based, and we use international guidelines called the NCCP. They're American-based guidelines. There's also European guidelines there as well. But within the survivorship guidelines by the NCCP, when they updated the guidelines this year, they've recognised that those living with metastatic disease should have the same principles of survivorship care applied to them. In Europe, the guidelines around metastatic breast cancer and survivorship and support, a little bit behind, it still focuses on disease status and the therapies and the toxicities and quality of life. But we are certainly moving on from a place where we weren't before. As part of the survivorship guidelines, exercise is number one. And again, one of the questions that came up when we were planning this meeting is, well, a lot of the exercise programs are for those who have had curative cancer. What about me who has maybe disease in my bones? Can I do this? Is it safe? Will I fracture a bone? So within the principles, we are still recommending that those with curative cancer, those with no cancer, those with metastatic cancer abide by the WHO recommendations for exercise of 150 minutes per week. It doesn't mean you have to be in an exercise class. It doesn't mean you have to be out jogging. It's around movement. It's around what you can do. And I've put up there a website that I like to use for people. It's called the PERCS website. It's a collaboration between St. James's Hospital and Trinity College. And they do online exercise programs. So you can do them to whatever level you want. It goes from low level to high level. You can do them standing, but they're also done with a chair. So easy to use at home. So often your goal is around movement. It's about joint stiffness, aches and pains, trying to prevent that from happening. Others, it's around cardiovascular health, getting involved in running. And again, we will support that. Survivors with bone loss or bone metastases in general should avoid exercises that place high load on fragile skeletal bones. Again, speak to your oncologist, speak to your radiation oncologist, whoever your lead is, and they will advise. I suppose if you have fragile bones, again, I'm thinking of maybe women on hormone medications like the anastrozole, the letrozoles of the world. If any of you are on it, they can make the bones a little bit more fragile and at risk of osteoporosis. So again, you're trying to think of exercise that will build the bone. And that's around kind of weight bearing and resistance. But again, we need to be careful of fall. So the type of exercise that you choose. And refer again, yes. So again, importantly, should anything develop while you're exercising, that you get medical advice early. Now, I'm not finished. I don't know what happened to these slides. I have, again, just around nutrition. Often a question comes up around nutrition and what is the right diet to be on. And again, we would refer back to our experts within dietetics. And they would always say to us that there is still no recommendation for omitting any food group. It goes back to a well-balanced diet, maybe something like a Mediterranean style diet, maybe adapting what you're eating to maybe snacking and eating little and often. Certain food groups may be aggravating than others. And again, we will support you with that. We have all those resources, booklets, websites. So just ask and we will refer. Again, I've put up another website. There's always questions around vitamins and supplements and CBD and can I and should I? And I don't want to tell you, but I am taking. We know that most people are taking things that they don't ever tell us about, and that's okay. But what I always like to refer people to is there's a very good resource online through the Memorial Sloan Kettering Cancer Center in New York. So if you go on to just MSKCC, if you Google that, herbs and botanicals, they have a very comprehensive list of various herbs and supplements and vitamins out there that you can just type in, and often it will tell you, you know, what is known, what is unknown, what their purported uses are, how those supplements work, and how it can affect your cancer treatment. So again, empowerment, informed decision-making. Hydration is key. If you do nothing else, drinking water just for well-being, side effect, we know that it minimizes side effects. It can reduce your risk of infection and clots. And just well-being. Again, from a health promotion point of view, we can often get very, very focused on the cancer treatment. So it's not to forget everything as well in life. So your vaccinations. So again, your nurses and doctors can give you the appropriate information around COVID and flu vaccines. What screening programs you should still be availing of it, be cervical check or be it the bowel screening program. healthy lifestyle modifications to prevent cardiovascular disease, around your bone health. You know, again, I mentioned increased risk of osteoporosis from some of the treatments, increased risk of fracture from maybe some bony disease, the use of calcium and vitamin D supplements. So again, often what I find around things like these supplements, people don't like taking them. So I would often have other options or other suggestions. So ask if you have been recommended something and you can't tolerate it, ask, and we can signpost you others. Some of you may be on drugs called Xgeva and bisphosphonates. Again, that's all around bone health, preventing fractures, strengthening up the bone, preventing osteoporosis. So we'll keep a mindful eye on that to make sure you're on the appropriate treatments for bone health, and advice around weight bearing and resistance type exercise. Managing fatigue and pain and lymphedema and menopausal symptoms. It's endless, the list, but it's about that therapeutic relationship, having somebody to ask the silly question or the question you feel is not important. Again, we will signpost you. Finally, I was asked to, I suppose, implement the role of palliative care in the treatment of metastatic breast cancer. And when I thought about it, I really felt the best way I could do that is share my experience of working with the palliative care team for men and women who have metastatic disease, but in particular from my experience of the oral therapy clinic, where I looked after a lot of women with metastatic breast cancer. And I suppose I would term it as active palliative care, in that it is a shared relationship between the medical or radiation oncology team, the community palliative care team, and the GP. Often somebody is still on very much active treatment. They're coming in and out to their hospital for their multiple lines of treatment. The palliative care team might just step in to effectively manage symptoms like pain where we're not qualified. Or you might be referred to radiation oncology for a short course of radiotherapy to the bone or another organ, to the lung. And that partnership changes. It's led out by the various disciplines at various stages. So often it can be oncology leading out the care and radiation and palliative care supporting. But then at another stage, it might be the radiation oncology team need to take over and we step back for a little time. So it's that dip in and dip out approach. And the earlier we can get palliative care in to help us manage the symptoms and the side effects of our drugs, because they have a huge plethora of drugs available to support treatment side effects, the better it is, I think, for living well on treatment. Also, I suppose when we come to a point where there is no other lines of treatment, from my experience, it is a much more accepting transition to palliative care. So I would remind you, I suppose, or encourage you, if it is ever suggested that palliative care step in for a little while to help with an issue or a symptom, maybe consider it, because it might be just for a short term and it's a supportive type of approach. And somewhere along the slides here, there it is. I just want to say thank you for your attention. Thanks for sticking with me. It was a bit all over the place.
We didn't notice anything there, nothing. What we did notice actually was a butterfly flying by. You see that, which is symbolic, obviously, of somebody coming to visit us today. So that's really nice to notice. Could I ask Miriam, Louise, and Ada to maybe sit on some chairs here? And we'll maybe take 5 minutes to do a question and answer session, if that's okay. I have answered a couple of questions online that I was able to do directly, so that's fine. If you have any questions online, please text them to me and we'll read them out. We have rescheduled afternoon tea for about 2:30 because we are a little bit behind, but that's okay. All right. Yeah, thanks. Okay, does anybody in the room have any questions?
Probably Dr. Miriam. Yeah. That's okay. Yeah. Could you say anything about lobular cancer that cannot be detected on any scan? It was detected through biopsy.
The question is, can I say something about lobular breast cancer? So I mentioned types of cancer in terms of hormone-driven, HER2-driven, having those or not having those. Another way of looking at breast cancer is it ductal cancer? Is it lobular cancer? Is it tubular cancer? Is it micropapillary? There's about 15 other types. So the commonest one is ductal, second commonest one is lobular. One of the things about lobular breast cancer in the MBC setting is that it can affect bones, it can affect the lining of the lung, it can affect the lining of the tummy. And the lining of the lungs and the lining of the tummy can be hard to see on scans. Scans are not magic. They don't detect everything. Sometimes in an earlier type, it might be easier to see it on an ultrasound of the breast than a mammogram of a breast. So it's not as easy to see it on some scans as other types. Is that great?
Okay. Anybody else for question? No?
So in my school, anyway, in my primary school, the master said, if there were no questions.
That's what it's generic questions.
Yeah.
Because I don't have breast cancer. I did have breast cancer, but I actually have metastatic bowel cancer. But I actually had a question for the nurse, for the NCCP and the nursing. I'd love to see the nurses actually a little bit more empowered to do more for us. Things like I do icing, which is quite unusual in the hospital. So they all go, oh my God, what are you doing? I'd love to be able to disconnect myself. So I was wondering, how can nurses help? How can patients be more empowered to bring new techniques to nurses, but also to make our care easier so that you don't have to go in to get disconnected? Now that's a bowel cancer thing, but I just wondering, how do you influence nurse, and what would you like to do more? Maybe that's the question. What could you do more for us to give us more options? Yeah.
Yeah, great question. And I think we're on a journey at the moment. I think there's so many treatments, there's so many specialties that there has been, I suppose, a dilution of nursing. So we've all kind of navigated into various specialities, and we all have our one. I think it goes back to education and nursing being able to come together to learn from each other. So I think COVID has been damaging for that reason. I'm at an oncology conference tomorrow, and actually some of the sessions that we're covering are exactly around that. You know, how can we be innovative? How can we apply digital health to our care? How can we improve the likes of the acute oncology services? So those kind of meetings are really important for nurses to come together. The challenge is to get nurses together to do that. I think money plays a part in it too. The nurse services that in the home that I mentioned, they're often privately resourced through pharma companies. So I suppose, again, nurses as patient advocates at policy decision-making on steering groups, nurses educating each other around. But I think as well, some of the websites that I mentioned there are from patients who have come in to me. Absolutely. Yeah. So for instance, the Memorial Sloan Kettering one that I mentioned there, that is somebody brought that into me and showed it to me, and then I brought it out. Same with various supplements or you know, I suppose, again, the bloods and things like that you mentioned, I would have been on the development of the community intervention team here in Waterford, and we advocated strongly that, you know, there would be an oncology wing within the CIT in Waterford at the time, and Miriam would have been instrumental of that in Kilkenny as a lead out for it. So again, I think it's just bringing the voice of the issues that the patients are having on the ground to the people who can make decisions. And often we can come with very common sense, you know, response, but it's just having the opportunity to do that. But if anybody ever has a solution or a tip or a trick, we love to hear it, because it can be rolled out to others.
say a quick thing. The nursing leadership at the National Cancer Control Program is very strong. So my colleague Terry Hannon leads up that program, and she has a very like close relationship, I'd say, with oncology nursing around the country. Now, in the survivorship program, we work hand in hand with her. So, you know, we're very, very close colleagues, but there certainly is a kind of a two-way relationship between that, and innovation and different ideas come all the time our way, and we kind of try to fight the battle internally in the systems, as well as, you know, reflecting what's actually happening at the services level.
Okay, well, I want to ask a question from online, and it's a practical question, actually, probably from Miriam or Ada. Can I fly with an acidic drain?
Thanks, Ada. So I encourage people to fly all the time. I encourage people to attend family events, go on holidays. I usually say to them two things. One is traveling is challenging. From when you either get on a bus in Waterford to getting on the plane is quite an arduous journey. So I ask people to think it through, to get as much support as they can. And this is whether they have an acidic drain, whether they have a pump, whether they have to bring an injection with them, whatever. So to think about the journey and think it through, are they able for it? So three things. Are they able for it? Brilliant, off you go. Think about if something happens when you're away. And I suppose this might be somebody who's sicker. And if I am concerned that something will happen, you know, check, is there a hospital nearby? I'll often say to people, there are people with MBC in every country you go to. So there are doctors and nurses who know what to do if there's a problem. And then the third thing I say, send me a postcard. I have a collection of postcards. There's nothing now, you know, people don't send postcards anymore, but I have a collection of postcards from all over the world, and there's nothing nicer than in my post is a card from wherever, the Northern Lights, Italy, Australia, Disneyland, and I'm sitting in my office bogged down and work, and I go, well, I'm glad somebody's on their holiday.
Thanks, Miriam, and I think you've really created the no borders aspect of today.
Sorry, I was hoping to travel to America and I can't get travel insurance. I don't have a private health policy. So
now you have it. That's not even a boundary, it's a discriminatory. And that's a real challenge, really is. It's a little bit like you know, an 80-year-old not being able to get travel insurance simply because of their age. And I have no simple answer for you. I can give a letter saying, you know, I have no problem with this person traveling. I suppose, and that's part of, where are you going? If something happens, what will you do?
So there is a company there's a company that's been set up, but it may just be UK. So it was insurance with, and it was but it was set up by a lady who has metastatic breast cancer. And so, but it is a UK company, but I would try and phone them and say, I don't know if you have, Tricia, if you have tried, but
I had PHI those, but I didn't have this.
yeah, so it's insurance with.
So there we go. That's exactly what happens in clinic. Somebody comes in and says something, and then we can share it around. So insurance with unashamedly and add a plug for the whole company.
Yeah, and it was set up for metastatic breast cancer, but I have a friend who I run with as part of 5K Your Way every month, and she has advanced lung cancer, 10 years advanced lung. So I got her I sent her the insurance details, and she has got annual insurance with them. So, you know, and that was advanced lung, and she's on treatment.
Thank you, Anne.
Somebody down the back.
Okay, this will probably be the last question because, but Miriam and Ada, are you around for a little while afterwards, or will you need to go back to your clinic? commitments?
Unfortunately, I'd say it's returning to work.
Okay. Okay.
Hello, I don't know if you have seen the painkiller series that's streaming on Netflix right now that talks about the MS counting, oxycontin. So as I'm the person that needs to take on a daily basis some strong painkiller because I have problem in my spine, it's something that concerns me a little bit about this medication, about the strong painkillers that you have to take on a daily basis. So what do you think about that? Something that they are exaggerating, or is something that you should concern about?
And the concern is that it will,
The medication is addictive.
okay, that it's addictive.
Yeah.
Yeah, so I suppose there have been many programs about the addictive nature of opioids, MST or morphine based as the class of drug is opioid. There are a number of them. MST would be one that's well known, or OxyContin, or and certainly in the US over the last 15 years, these drugs have been used and abused and the freedom to prescribe was far more liberal than the restricted prescribing we have here. So they've been given out for people who've had a sprained ankle, who've had, and in that setting, there is a high rate of addictiveness to it. In the advanced, so here in this country, there's restricted prescribing. And there are rules and regulations about how many can be prescribed at a time, what the dosage is, and how we prescribe it. There is very little evidence to support that they're addictive in the cancer setting. You can't say that they're not, because there's no doubt there is an addictive element to them, but certainly in the cancer setting, we use them a lot for pain control. They're also used sometimes for difficulty with breathing. So I see very little addictiveness to them, thankfully.
Okay, thank you.
Okay, well, it leaves me then to close off this session, our first session of the afternoon. Miriam, Ada, and Louise, thank you so much. It's very obvious that we all work very well together nationally. You have a wonderful MDT setting, I think, in UHW, very lucky. Jennifer is in the audience. Sorry, Jennifer, for calling you out. Hi, Jennifer, how are you? You're very welcome to Waterford. So principal psychologist within UHW as well. Fantastic service. And, you know, as Patricia and many women in the room would say, and I'm sure partners would say, you know, you need to find your nurse. You need to talk and ask questions to your clinical oncologist. Make the most of your meetings. Very open and accessible, very friendly and very direct. But thank you all for your contribution and your commitment. So we'll just take a couple of minutes. I'm not sure if we all have time to go to the toilet because it's actually down at the cafe. I really want to get Siobhan and Anne mic'd up here. Probably very quickly, if that's okay. No, I don't mean to rush. So, Siobhan is eager.
Okay. We'll stand up. Okay. No, fine. Miriam saying she can't see us in the back, so.
Everything's okay?
All okay? So, it's, we don't work. Okay, ladies and gentlemen, I'm going to break up the party again. I'm sorry, I'm such a party pooper. So welcome back to our second session of the afternoon. And this session really is especially for you. I really need to maybe make comment and take in this room. It's beautiful, isn't it? The wallpaper is 200 years old. It's Chinese and it's hand painted. And it's painted with craftsmanship, with passion, commitment, and focus. And then within the room here, we have two beautiful ladies, Siobhan and Anne, who have served really in the world of metastatic breast cancer, advanced breast cancer, whatever we want to call it, as Miriam was talking about earlier. There are many names. I like ABC as well, actually, Miriam. But, you know, they have shown passion, commitment, determination, I would say as well, and rigorous focus and time, their own time in their lives, to be here today. And to talk to you and work in partnership with you around metastatic breast cancer. You know, there's a legacy in this room, and I believe, strongly believe, that Siobhan and Anne, together with you all, are going to leave a legacy for those who come behind you, to live your best lives, to make sure that we're all committed, to make sure that we all have a passion behind, you know, the lives of women and men with metastatic breast cancer. But to make sure that, like, clinically, people are aware, you know, that in hospitals, doctors, nurses, psychologists, medical social workers, anybody who's involved in metastatic breast cancer are very aware of the disease, its limitations, and what it causes for families and friends. Ada, you talked a lot about it as well. You know, the effects And the uncertainty and the certainties of this disease can be crippling, but they can also be very enlightening. You know, scary as it is, these ladies are very enlightening. So I'm going to introduce them individually also, because I think it's really important to give time to what these ladies have really done. So Siobhan Gaynor, you'll all know, is infamous, famous in this room, was researcher to patient and is now patient researcher, a scientist by profession, and worked in medicines, research and development, including clinical trials, for over 30 years. When diagnosed with primary breast cancer, her knowledge really helped to accept and understand it quickly. She knew the incidence and risk factors and never took it personally. Once finished active treatment, she was more than happy to move on with a renewed sense of how life should be and how precious life is. But metastatic cancer was a completely different animal, and it forced changes to her life that were difficult but necessary. She needed to step off the career ladder due to symptoms of the disease. MBC is currently incurable and is therefore life-limiting. A very proud member of Positive Living Group facilitated by ourselves, and a member of Cancer Trials Ireland Patient Consultation Committee. And we all know, anybody who knows Siobhan will know that she has had lots of plans, made many trips, and is making beautiful memories with family and friends. So thank you, Siobhan. And we have Anne McBrien, NHS Manager to NHS Patient Advocate. Anne worked as a senior manager in the NHS for 34 years and had just completed an NHS Leaders Quality Improvement qualification. So she seamlessly moved from being an NHS manager to an NHS patient advocate. She's still working on improving NHS services, although time is a lot more urgent now. Anne lives in Belfast, so thanks for travelling down, Anne. She turned 60 this year, and breast cancer has been part of her life for the past 10 years. But I can tell you it hasn't stopped her celebrating. She hasn't stopped since. So Anne was initially diagnosed with primary breast cancer in 2013, following her first mammogram. So mammograms are important. Her annual review is clear for 5 years, and in 2019, she was discharged, considered cured. Just 2 months later, she was diagnosed with MBC. Although initially devastated, she adjusted to her diagnosis by trying to take control back. She researched scientific papers and viewed oncology podcasts, or viewed and listened to oncology podcasts. She then wanted to use this information to help others to make improvements in services. She engaged with the Department of Health, joined the National Northern Ireland Cancer Research Consumer Forum, and is the Northern Ireland Executive for MetUp UK. Anna is passionate about exercise. She feels incredibly lucky. She is still on her first line of treatment and has remained stable for 4 years now. Her focus is living her best life, doing the best she can with the time she has. Family, friends, patient advocacy, and exercise are her focus. Thank you, Anne. So we're going to now open up the floor, I think, and Anne and Siobhan are going to talk about their own experiences and the work that they're doing. And then we would really appreciate, you know, if we can have discussion from the floor. That would be really good. Are you both okay?
Yeah, thanks. Yeah, thanks very much. I knew my brooch was going to come in handy because my mic's on it. It's a ceramic brooch, so it'll probably break in the middle of it. It's so lovely to see a room full of new faces and old faces as well. So that's really nice. Helen has probably started the conversation for us, but I'll just let Siobhan, just if you would tell us just about your metastatic breast cancer diagnosis.
Sure.
For you.
So firstly, just for clarity, I was diagnosed with stage 2B primary breast cancer in 2019. I was 51 at the time. I self-discovered a lump and presented to my GP. Hadn't actually been called for my screening mammogram at that point, so I self-referred. So obviously went through the treatment, decided in my case, my Oncotype DX score was intermediate. So along with my oncologist. And I think that's a very important message I want you to all understand, is that it's a very collaborative approach that's needed with your medical team. And very much I felt in the forefront of driving my own treatment decisions. And so I decided to have chemo because of a number of factors that were going on in my own life. Unfortunately, post-treatment, post-surgery, radiotherapy, chemotherapy, went back to work January 2020, gung-ho, felt, wow, this is great. I'm going to obviously be much more aware of my life now and treat it much more preciously, started exercising more frequently, but I just wasn't able to get fit. I just found it was a real struggle, and I'd done it a few times before, and I was getting pain. So I then went to my GP in the middle of the pandemic and was referred for an MRI, and unfortunately it was the news. And whilst I've worked in the area as a scientist and as a clinical researcher, knew the numbers, knew the statistics, I don't think any of us ever believe it's going to happen to us. I think that's the reality of human nature. So I knew that a third of us at some stage will end up having metastatic. I knew that there's the de novo that presents stage 4 straight away, but I really didn't believe it was going to happen to me. Unfortunately, it did very shortly thereafter. And by the way, I've subsequently been diagnosed as I had de novo metastatic breast cancer all along. So that was my own particular story. And thankfully I'm on stable, like Anne. I'm on the same first-line treatment for the last 3 years. My subtype is ER positive, HER2 negative. So I'm on Ibrance and I'm on hormone therapy and bone strengtheners. I've had a few dose reductions on my Ibrance, and I've also had a chemo holiday as well along the way. Just wanted to make you all aware of there are options out there to maintain your first-line treatment as well. So Anne, can you tell us a little bit about your own diagnosis?
Okay, Siobhan, well, Helen has covered that, and I was actually diagnosed with my primary breast cancer about the same time as you, same age as you, not the same time because you're a lot younger. I had just turned 50 in August, and I got my first screening. I was at a meeting, I worked in the health service at the time. I was at a meeting with my boss, and it was the screening centre was downstairs. And he said, where are you going? And I said, I'm going to my screening clinic. And he said, okay, that's fine. Went to my screening clinic, detected a lesion which was so small that it actually was removed with the core biopsy at the screening clinic. I therefore had minimal treatment. I had minimal surgery. I had a lumpectomy. I had radiotherapy, and I was put on endocrine therapy or hormone therapy for 5 years. Interestingly, I was considered low risk, and I was seen as the poster girl for early detection through screening, and I was put on self-directed aftercare, which meant I had mammograms every year for 5 years, but I didn't see my oncology or my surgical team, but I could access them. So after 5 years, I was taken off endocrine therapy. I had clear mammograms for the 5 years. I didn't see anyone. On my last visit, I did have a review, and everybody said, off you go and lead your life. And I had been leading my life anyway, because I always thought of myself as incredibly lucky that I was caught through screening. 2 months later, I had some shoulder pain. I got an MRI, and it detected that I had metastatic breast cancer in both lungs. I'm HER2 positive. And so I really did not understand how that had happened, because 2 months earlier, I was seen as cured. I was the poster girl for early detection, for self-directed aftercare, and my world fell apart. I was just so shocked. But Anya put it very well this week in our WhatsApp group, and she said, everything's black and white initially, and then colour returns. And colour has returned for me, and it's returned for 2 reasons. I'm living very well. I run with my oncologist, so that's very special. We only do 5K once a month, but that's very special. And we have different conversations during that run, things that you can't talk about in clinic. The second thing is 4 lines. I've been stable on 4 lines. I've been stable for 4 years, sorry, on my first line of treatment. But the one thing to give everybody some hope is when I started this, when everything was black and white, I didn't have as many treatment options. 2 new fabulous drugs have come on board. One is in HER2, I don't know whether you have it in Ireland, but we have it in Northern Ireland. It is Herceptin. So that has come on board for me, and another drug which I can't pronounce, Tucatapanib, which is particularly good for brain mets. And I know HER2 positive, you know, I know I have a high likelihood of developing brain mets. So two things that are huge for me to come on board in 4 years when I have been stable has meant an awful lot to me.
So Anne, what actually got you interested in patient advocacy?
Yeah, so it was that shock, really, that initial shock. And I really knew nothing. Despite being a very informed patient in my primary diagnosis, I had copies of my scan results. I felt very in control. I had done everything correctly. So I had no idea what metastatic breast cancer was. I had no idea that when it returned, how it could return, nothing on signs and symptoms, nothing on the risks or the incidence of it. So I thought I wasn't going to be caught short again. So information for me was power. So I wanted information for me on my disease. I wasn't going to be caught short again. And then I kind of stepped back and I thought, if I can help myself, I want to help others as well. And that transition was really easy for me because I was an NHS manager. I'd done the quality improvement course. I was involved in helping to improve systems in the NHS. And then I wanted to do that from a patient's perspective. And so I have been involved in lots of things. And there's one thing I would have to say, because some people have asked me about advocacy, you really don't need to know how health systems work or how they don't work, because we all know that they don't work at times, and it's very difficult to navigate. And sometimes the best advocates are those people who come at it with fresh eyes, who actually don't know how things operate and ask questions. And the other thing is timing. And initially, you know, I was on docetaxel. I did 6 rounds of docetaxel. All I could do was care for myself and get myself through that couple of months. And that was a real focus. But coming out of that, you know, there was colour. And so I was able, and I had the energy and I had the passion to do it. And I also, that was with the energy as well. So timing in this journey, Miriam talks about it being a roller coaster. And there's times when you can do things and there's times when you can't. And don't you beat yourself up about the times you can't. Take care of yourself, because in the other times you will do things for your own passion with your own energy. So, and what about you, Siobhan?
So for me, well, first of all, as I said earlier, you know, I felt there was a massive difference between primary and metastatic for it straight away. And I really felt at sea in the world of metastatic breast cancer. So the first thing I did was seek out support. And thankfully I found Positive Living from the Marie Keating Foundation, and that's been absolutely phenomenal, both in terms of support, but just, you know, having a group around you who get you, know what it's like. There's very little explanations, you know, as we all know, you know, with very quickly within these support groups, the very good ones, you know, you get to know people very quickly, beyond surface level. You go very deep very quickly when you have a life-limiting condition in support groups. And I can't emphasize enough how important that was for me. And I see and witness it every day. So I also, as a scientist, I suppose, I look at things and I think about, well, what, you know, is there any way to improve it? And through talking in the group and through more and more patients I met with metastatic breast cancer across the island of Ireland, I realized that there was a lot of inconsistencies in our care. Some of us are seen every 3 months, some every 4, some every 6, some by oral chemo nurses, some by, so there's huge variety. And what I realized, that there was also some gaps, particularly around the non-tumor stuff. And then I started looking at the literature, because that's what you do as a scientist. And I looked at the data and I was actually frankly quite horrified at how little data there was 3 years ago on metastatic breast cancer. Outside of clinical tumor stuff, I was actually horrified. And so that's a gap, you know, and that's what science does, is it comes in and looks at the gap and how do we change this? So that was what drove me, because I realized there was a problem. And I realized that there are things that you can do with it. So I really felt engaged at that point, and that's where the work started. So what have you been involved with, Anne, as a patient advocate in Northern Ireland?
Well, I went to a restaurant in Waterford last night, and the waitress said she'd been in Belfast at the weekend, and she told me everything she was doing. And I thought, oh God, we're really hip and trendy city. And she said, it's like what Ireland was like 50 years ago. Yeah, and I'm meeting Trish on Monday. So, but I would have to say, hopefully, what I tell you about now will mean we're 50 years ahead, not 50 years ahead. But anyway, I suppose it's back to this timing thing. It just so happened I had finished my docetaxel, and the Northern Ireland draft cancer strategy was out. And being a good old NHS accountant, I knew something, if anything was going to get funding, it had to be in a strategy. And if it wasn't in a strategy, it would never get money. So I read diligently the 144 pages of the draft strategy. And I have to say, I was really mad and sad, because in that 144 pages was one paragraph for metastatic disease. And it was metastatic disease, not for breast, metastatic disease generally. And yes, there was a lovely section at the end, which was about living well, but that was all about dying well. So I wanted to see something that would keep us alive and well. So that really was the thing that drove me. This was a once in a lifetime. It's a 10-year strategy. I was well. It was a once in a lifetime opportunity to change, or to try and change things. So I got a group of women together, and we put in a very long response to the strategy, but we started a campaign for change, and it was around four really simple things. Data, we're not counted. Metastatic breast cancer patients are not counted when they're alive. They're only counted when they die. So we've no idea how many people are living with the disease. And that is why it's so good to see new faces here today for me. So we have no idea about that. Drug access. We follow NICE guidance, but of course, like everything in Northern Ireland, there has to be another rubber stamp. So something is approved at NICE in England and Wales, and we have to wait until it goes through committee after committee. We wanted that so that it's immediate. The third thing, which is something that Miriam talked about, and I'm really pleased that you talked about this, was we had no metastatic breast cancer clinical trials in Northern Ireland when the cancer strategy came out. And that wasn't even seen. And that wasn't even seen because there's loads of early breast cancer clinical trials. So everybody kept saying there's loads of clinical trials for breast cancer. There was none. So we started to shine a light on that. And a secondary breast cancer clinical nurse specialist. So that's the model in England, in the UK. And so, but we had none in Northern Ireland. So 4 aims. So I'll just talk to you about the main thing that we achieved. There was, honestly, I can say I worked harder in my role as an advocate than I ever did it in my NHS role, and I worked really hard in that role. But every night, emailing, knocking on doors, to politicians, to Department of Health, Zoom calls, on the TV. You know, we did everything to try and raise these 4 issues. And after about a year, we got nowhere. Charities, we got nowhere. And then we got a call one day by a local charity called Cancer Focus, and they said, we know you've been round the houses, girls. We know you've been everywhere. We're going to get a funder and we're going to pick that up. And they funded the first metastatic breast cancer clinical audit, which will happen in Northern Ireland. And not only will that count us, it will also give us information on survival rates by subtype. But the other thing, which is so important, it will look at variation in care across 5 trusts in Northern Ireland. So it will try and improve services. So we will be counted and we will have improvements in services. And that's not for me. That is really that's the legacy for those that come behind. And the one thing that was really poignant for me, and this is what drives me forward really, was when the audit was launched, one of the main campaigners with myself, Julie, was 39. And when we were interviewed by the BBC and we had our press release, and it was Julie and I and Cancer Registry, so it's the Northern Ireland Cancer Registry, which is a government body, is doing this. So it's going to be a proper audit. On that thing, Julie said to the media, for the first time, we'll be counted when we're alive, not when we're dead. And Julie died 2 weeks later. So that's what drives me forward in patient advocacy, when you want to make a difference for those who come behind, and you know the work that those who have died have put in, so you want to recognise them.
So what about other areas? I know the audit, you know, is fantastic achievement and well done, Anne, but did you find that there was associated or corollary areas that were brought to life as a result of just shining a light on one particular aspect?
Yeah, so Siobhan, the interesting thing was an American lobbyist called me one day and she said, I don't know what's happened, Anne, because you've come from nowhere. And she said, anybody is talking about metastatic breast cancer these days. And for me, that was an awareness, and that we were living, and we were living well, and we were actually getting out, and we had a voice, and we weren't afraid to use that voice. And I thought that was really powerful. So we have made some inroads on the secondary breast cancer nurse. We've made some inroads on sort of the drug access, but the most important thing is we have 2 metastatic breast cancer clinical trials that are happening in Northern Ireland, currently recruiting, and 3 more in the pipeline. So I just think, you know, we do need to use our voice. So enough about, hopefully you'll realise Northern Ireland's not 50 years behind that. So enough about what's happening in up north. And Siobhan, what about you and the metastatic breast cancer research that you've been doing and the survey? Do you want to outline?
Sure. So I suppose for my personal campaign, to present it in that way, first things first, I decided that there certainly wasn't enough metastatic breast clinical trials in Ireland, or indeed in many other jurisdictions. So I could have some influence, I hoped, by joining Cancer Trials Ireland, who are the body responsible for bringing clinical trials into Ireland. I joined there as a patient rep 3 years ago, and we're working hard. It's always complicated, as navigating any system is, but we are trying to both raise awareness, but also improve and increase the number of metastatic breast cancer clinical trials, in full recognition that we can't all, you know, certainly I'd love to see a point where all of us are offered clinical trials at some stage in our journey, but it's very hard as a small nation to deliver for every single subtype. But with those constraints in mind, I sit there permanently, and I'm very pleased to say that, you know, you're on a very equal footing as a patient, which is actually very powerful. You know, I sit in Cancer Trials Ireland as a subgroup of the board on the patient committee. That's very strong patient commitment. So, you know, in that sense, there is hope. And I am listened to. I made sure I am listened to, but I am listened to. And certainly people come, oncologists and radiation oncologists will come and speak to me about, you know, the realities of the condition. And basically, we're getting recognition as patients that we are experts on our own disease. And that's very rewarding. And it's certainly utilised. I worked in patient advocacy 10 years ago on the other side, on the researcher side. And certainly that level of respect and movement and change was not present. So I do see a lot of hope there. So what I decided to do was, I knew that, frankly, the realities of this disease, I'd love to, you know, as a researcher, find the magic bullet, but I'm fully aware that doesn't exist, and transfer it into a clinical trial. But I don't have the time. None of us have that time. I don't know how much time I have, but I certainly was very aware of time. So I decided specifically to focus on a survey. I started to look at the literature in more detail, and I realized that it was the non-tumour things, I call it the non-tumour areas, like social care, whatever you want to call it, that was very limited in terms of representation in the literature, but also knowledge. So, you know, if a doctor with all well-meaning nurse in the world wants to implement a change in a service, you really need data to support that. You need evidence. And I always believe that as a scientist as well. So I needed basically to deliver evidence. So I thought a survey was a good start, in the sense that, you know, it's a relatively fast turnaround in terms of implementing it and getting it up and running and getting the results. Because if I'd done any other, you know, highfalutin type of methodology, frankly, I wouldn't have been around to see the results. So I felt a survey was a really good start. All of you helped me. This time last year, we actually sat in this, not in this room, but in a similar room, and talked about what topics were important to us. So I focused the survey on things that people felt were missing in our care, or things that were very important to us. So those are the 2 areas that we looked at. And I'm delighted to be able to tell you, we opened and launched the survey on the 20th of July. And this leaflet's for everyone in the audience with the QR code. The survey's still open. As of last night, there's 225 Irish, across the whole island, Irish metastatic breast cancer patients who have fully completed all 56 questions. So I just wanted to thank you all. So, you know, tips and tricks I learned along the way. It's not my comfort zone, but PR was key here. We put money in a budget for PR, and that was the most sensible spend of the budget lines in terms of, it was pretty exhausting. We did lots of radio interviews, TV, lots of, you know, of fancy stuff. I had communications people working with me. It wasn't my area of expertise. And I really felt that kept the ball rolling. So basically what we've done in a period of 3 months is actually, because I have some updated figures around incidence of metastatic breast cancer in Ireland, we believe that we have, as of today, 3 to 10%, it's a range, that's all we can get to, 3 to 10% of Irish metastatic breast cancer patients are represented in the survey. Now that's incredibly powerful. You know, that's amazing. That's a fantastic. They can't not listen to us now, you know, with that level of knowledge. So the survey, basically, so that's where we are.
Yeah, so I mean, thank you so much, Siobhan, for that. And I think it's a huge responsibility on you, because you have huge numbers, but it's a huge responsibility on you. So what's your next steps, and what do you want us to do?
Okay, so next up, and this is where I want your input, you know, so, you know, frankly, the survey focused on, I'll go over the 10 areas we covered very briefly. So the survey looked at, and this was, you decided this, not me, and that's really important. So it's representative. In the survey, we're looking at people's knowledge of their own condition. Are they familiar enough with it? Have they got enough information? Where do they get the information from? What their experience was like receiving both their diagnosis and their prognosis. Do they want to get a prognosis? What information were they provided with? Do they want better information? What supports are available to help us, particularly living with uncertainty? What experiences they have and what they'd like to see done better? And actually, I think this is really hopeful. You know, we want more information, and this was very clear around sexuality, fertility, and intimacy aspects. You know, if I'd asked those questions 10 years ago, people say, but you're dying anyway, right? What do you need to know about that? I actually think that's really helpful. In other words, we want to bloody live, right? I actually think that's really powerful. We want to know more about exercise, and we want to know what we can do. And Miriam gave us some good guidelines there, and Ada. And we want to know more about palliative care. So I think it's not too far from, you know, while we haven't analysed results, just in terms of finishing out that, we're actually going to close off the survey in the next week or two. So please complete your surveys. This is your last chance to get your voice heard. So once that's analysed, we'll have it quickly turned around. We'll have results by the end of November. I'm very confident that there's a huge there's a huge concordance, or people have very similar views, actually, from what I've seen preliminary data. Essentially, what's really surprising but really powerful is that we all want the same thing. We all want more information. We all want more supports, and we all want more guidelines. So basically, where I see us heading with this, and I want your opinions too in a minute, but where I see us heading, this is my personal opinion, but I need you all to feed in, because it's not just about me, it's about all of us. What I want to ask for in the recommendations, but I want guidance from you. I want to see an Irish medically verified website that provides us with up-to-date information, very similar to This Is Go for gynecological oncological cancer. That to me is gold standard, the This Is Go website, if anyone wants to have a look at it. I want something similar for breast cancer, and in particular metastatic breast cancer. Secondly, what I want is implementation of the guidelines. We talked about the NCCN guidelines, the ESMO guidelines. We don't have Irish guidelines that are actually implemented, but not, more importantly, funded. Okay, that's important to recognise as well. So I want to see that happening. And finally, what I would like to see, and we talked a lot about the survivorship model, and that's wonderful to see that being rolled out. But actually what we need in metastatic breast cancer, I think, is a very similar model of care that they have in survivorship for stage 4 cancers. And I think there's a lot of similarities between the stage 4 cancers, the more patients I've spoken to. So in fact, we're looking for a similar survivorship service for patients. But I want to know what you think.
Will we open it up?
Yeah, please.
Well, thank you both so much for that. You want to take seats or?
Yeah,
Yes.
I'd love to hear, you know, those are the things I think we need, but does anyone else have any asks? And I will be taking notes because I haven't typed up the recommendations yet.
Anybody got any burning questions or thoughts or supports? Thanks, Roseanne.
I promised Anne that I'd ask a question when she got up so that there were no questions. So it's not so much a question as such, but I've found over the years that I have much more in common with stage 4 cancers of other types than of primary breast cancers. And it's because stage 4 is a lot more mental. I think there's a lot more that's going on in your head and a lot more that's sort of, how do I do the long run? How do I, you know, keep going? How do I not let it be my life, but be like diabetes, something you have rather than something that you are. So I suppose it is that thing for me, like you were saying, that stage 4 thing across the stage 4s. We are all facing very similar things. It's only your medicines and stuff that I feel are different.
And I actually think as well that I actually think there's quite a lot of support for metastatic breast cancer in support groups.
Sorry, I'm here.
Yeah, but that's what I actually think the other metastatic diseases don't have as much at all. And that's one thing that I thought. You're so right, Suzanne.
Yeah.
I think we are more privileged, and that's probably why we're a little ahead.
Yeah, because there's also, when I was first diagnosed, you know, you get sent to the support groups, and I was in a support group, and there's a lot of early stage people in me, and they were all terrified of becoming me. So you can't talk. You are the elephant in the room. So it is good to be in a place where you can let it out and be upset. And everyone, as you said, the side head, it's the first thing everyone goes, yeah, the bloody side head, I want to move it. There's understanding there amongst ourselves.
We're not going to ask you how many sessions. Yeah. Thanks, Roseanne and Tricia.
Practical thing I go to see in hospitals, and now I do go to private clinics, so maybe that's separate. I would love if the Purple House form was given to me, signed by the doctor to tell me to go to Purple House or ARC, instead of me having to go to the centre, meet them, register, get a form, bring it back to my doctor, get him to sign it or her. And then when I ring Purple House, and I know I'm in Dublin, sorry, so I was here, then they ring and they say, oh, you come back in with the form, we put you in a wait list. I'm like, can I just email you the form? Like, could we make that process a bit more simpler for the patient? That would be a request. It's a practical request. Yeah, sorry.
I actually, when I worked in Vincent's, I did, of course, yeah, because I would have done referrals to the cancer support centres, particularly Hope, actually, from St. Vincent's down to Hope. And they would have taken those and then, you know, brought the person in. Yeah. So is that the way it works in Waterford?
Yeah, certainly. I used to get those forms sent in from Solace, and it needed my signature before somebody could get go ahead.
Yeah.
I have never in my life not said somebody could have Solace. So I spoke with Solace and I said, stop sending me the forms. This should not be a block. So what I get now is from their to protect them, is a copy of a form that they're attending Solace. So it's not a block anymore. So I think those things, that's a really good one.
You know, just really small things that don't cost money. That's free change. Don't need so get more patients. But I do think it's small things.
Yeah, yeah.
It's even things, you know, you can have 6 sessions of. Sometimes I find that really difficult. You know, you can have 6 sessions of this because that's what you give a primary breast cancer patient. And, you know, exercise, you just think 6 sessions. Well, could you not actually extend it out? Because maybe I need a bit more than that because maybe I'm not well. So I think what we have done is taken a primary early breast cancer model and just assume that that's going to be okay for metastatic for the non-tumor stuff. And I just think it's nearly actually thinking about a patient rather than just the system. You know,
Okay, I just want to thank everybody who's online. We've had lots of thank yous coming in for Anne and Siobhan, and total respect for the work you're doing, and keep on doing what you're doing. So yeah, they're really benefiting from the conversation. So that's from our online colleagues. Anybody else want to say anything from the floor, or are we finished? Okay.
So just one, Francis.
For their energy and their go-to and just get things done. Because I don't think I have that in my personality to do it, but I am in awe of your abilities.
The most rewarding thing that I found from doing the survey is because there are other effects, you know, it's driven awareness. I know that from conversations I've had with many people over the last 6 months. But actually the most rewarding for me personally is the emails I get from patients who've done the survey, who say to me, thank you for giving me a voice. That's extremely powerful, and that's why I do it.
And sorry, can I just say as well, I'm a long timer. Have secondary breast cancer, or ABC as I now call it, for nearly 18 years. And I have felt so alone in the very, very beginning, because initially, you know, I wasn't even seen as, you're not really, you can't really have radiotherapy because you're not in the box and whatever. Eventually I did, and I kind of felt, okay, I'm kind of like everybody else, which sounds absolutely ridiculous, but that's where my mindset was. And there was really nobody that I could know of. So when positive living came up, and I know I've dipped in and out, I just want to say again, thank you to Marie Keating for that, because the aloneness somebody can be at a place where they're not like everybody else, is huge. So thank you very, very much, Helen, for all that, and to Marie Keating.
Francis, that's the first time I've seen you in the flesh, and it's lovely to see you. Thank you. I'm going to hand you over to Liz Yates now, our CEO, to say final steps and take us on our step-by-step over to afternoon tea. And Ray, I know, is waiting in the wings to give us a lovely demonstration and talk around, the gardens and the cafe and the house itself. So over to you, Liz.
Thank you, Helen. And just want to say it's been the most inspiring and powerful couple of hours here we've had together. Metastatic Breast Cancer Awareness Day is a really important day in the annual Marie Keating Foundation calendar. I think it was back in 2016 when we did our first seminar, and I think survivorship was a new term at that point. Louise talked about the fact that it was only mentioned in the most recent National Cancer Strategy. And the Marie Keating Foundation, as an organisation that makes cancer less frightening by enlightening and puts patients very much in the centre of everything that we do, realised very, very quickly that there was a huge cohort of patients here who had those feelings of loneliness and isolation and didn't feel like they belonged in terms of other support groups. So we started off with a Survive and Thrive programme, which was for cancer people who have completed their treatment. And then we realised, no, we need to do something very different because the needs are so different. As Miriam said, no two cancers are the same, no two journeys are the same, but particularly with advanced breast cancer or advanced cancer in general, it's a different cohort of people who have that where we could bring people together who have that mutual understanding of what it's like to stand in your shoes, and facilitated by Helen. We started off, I think, with about 12 patients who are living with advanced breast cancer, and COVID, surprisingly, actually enabled us to increase the numbers hugely. And we have now, because people were suddenly able to come online from the comfort of their own living rooms and join with other patients and receive the guidance, support from specialist speakers and facilitated by Helen. So we now, I think, have a panel of about 70 people from all around the country. Also loved ones and family members benefiting, dipping in and dipping out. Some subjects will not be of interest, but what's wonderful is how you're all supporting each other, and how, you know, just to hear the powerful stories from Siobhan, from Anne, the inspiring story from Francis. How many, 14 years, did you say? 18 years. I mean, how inspiring is that for everybody else to know that people are living well, and that's what it's all about. It's living well. It's not just living with. Wonderful to see so many new faces at today's seminar. I mean, we know so many of the positive living ladies who come along month after month, but it's fantastic to see so many new faces. You're also welcome to the Marie Keating Foundation family, and we hope that you will be part of our group going forward. So October is a big month for us, but Metastatic Breast Cancer Day is a very big day for us, and something that we hold very dearly. And we're here to support you. As Helen said, we are with you at every step of a cancer journey. And this, you know, stage 4 cancer is a really important part of a cancer journey. That journey has its ups and downs, but we're with you at every step. So without further ado, I'd just like to thank everybody, all our expert speakers, Miriam, Louise, Ada, Anne, Siobhan, and particularly the Marie Keating Foundation team. So Linda, Fiona, Jane, Bernie, but particularly Helen, who put today's event together, who is inspirational in terms of facilitating the positive living group month in, month out. But I think does an amazing job as our Director of Nursing. And Helen, well done. Thank you so much. And thank you for hosting us here in this amazing venue. It's absolutely beautiful. We're really looking forward to hearing a little bit more about the history. And it's so nice to be outside of Dublin. And I'm so delighted that so many of you made the journey. The sun is shining now. So we'll hear a little bit more about the venue here, and then hope you'll all join us for afternoon tea. So thank you so much.
Hi, everyone, and welcome to Mount Congreve. Helen had given me some brief pieces earlier to say about, I'm going to make sure that you all leave here on time so you'll go across to get your afternoon tea. I had a list of things to say to you, and they all seem a little bit insignificant, to be quite honest. And I know I've heard a lot of words here like inspired and inspirational. And I've got to tell you, it really is like, we've had a lot of events in this room, but it's palpable, the real sense of community and the real sense of how you inspire each other and how you help each other. It's kind of taken me aback a little bit, which wouldn't normally happen. Like how you deal with this is inspirational. What you do, what work that you do with the Marie Keating Foundation is incredible. How you all support each other is incredible. Like I think of some of the events we've had in this room over the last 6 months or so, and it's all corporate speak and moving forward and all this flim flam stuff. And it just all seems insignificant. It really does. Like, so I want to say thank you for bringing that to us. It's great for us to have organizations like this that come here. And it's great to see this room getting used for something that's important. And I mean important in the very sense of it's important not just to the people in this room, because we've all been touched by cancer in some form or other, everyone here and everyone outside the room. So where I normally tell people, look, thank you very much for coming here and we appreciate the business and we appreciate it. And I mean it. I absolutely mean it. this is giving us something different. This is giving us a different level of appreciation. What we have here in Mount Congreve, and I'll give you a brief piece of the history. It is a world-class garden. It has an enormous collection of plants. It's got the largest private collection of plants probably in the world. And that's because the guy who built the gardens had a big ton of money. And he retired at 65. And this is the part that I find a little odd. He retired at 65 and he decided he was going to spend the next number of years to develop the best garden he possibly could. He lived to be 104. And about a week before he died, I was talking to him in the library, and he was, I'm not making any of this up, Tommy over there, who I know for years and years, worked here years ago doing the audio piece, the frontline visual. And he said, what's wrong with all you young people today is stress. Now, this is a guy who was 104, chomping on a cigar. He just had his cornflakes, which were covered in cream, and that cream was covered in, and I'm making this up, that cream was covered in sugar. But he maintained that what kept him and gave him longevity was the gardens. And it's absolutely true. So I know everybody here has their own struggles, and it is inspirational to hear how you've dealt with that with courage and humility and collaborative effort between all of you. It really is something. From the gardens again point of view, they decided, because I asked them to leave it to me, he didn't. I'm not any connection to the family. I told this lovely lady earlier, I'm from a council house across the river, but I worked my way up into this position. So the plant collection itself is spread out about 16 kilometers of pathways in 70 acres of gardens. And we do a number of events throughout the year, and some of them are really beneficial health-wise: mindfulness, meditative walks, forest bathing, which when I heard it first sounded like loads of fun, but it's not as much fun as it sounds. All of those things help, and you do get something back from nature. And I know ye are aware of it. So if you do have time today, please walk in the gardens. And if you don't have time today, go and walk in an outside space or a gardens near yourself. We're only lately becoming aware of how in tune we are with nature, and how that distance between ourselves and nature is what's caused a lot of problems, we think, in how the earth is being treated. And I won't give a lecture about climate change or anything like that, but it's when we lose that connection and we lose that level of caring about the things around us, that's when damage happens, in particular to the gardens or to the earth. Not the way ye are here. If you could replicate the feeling ye have and the connections between yourselves outside of the room, it would be incredible. Trees, I sound like a total tree hugger because I am a total tree hugger. Trees, believe it or not, help each other through their root systems. If one is suffering, they'll give it nutrients. If one is suffering from drought, they'll give it water, pretty much. So it is in that space in nature that we have here that we find all the benefits. And it is, like I said, it feels insignificant. It feels like it's not really important. The gardens were developed by Mr. Congreve from the 50s on, and previous to that, there were 5 generations of Congreves. They bought the ground here, which we always like to mention. It isn't one of those estates that was taken off the locals and then developed up. And the Congreves have always been involved in the local merchant bankers, industrialized shipbuilding. They've done everything that is in Waterford. The Congreves have been involved in some way or another. So Mr. Congreve, because I asked him, said, well, I'm going to leave these gardens and this house to the state because it's the only organization that I can trust. So that was his opinion. So he left it in trust to the state, and it will be handed over fully in 2032. And our job, my job as the estate manager, and Danny, who some of you have dealt with as the events coordinator and our commercial director, our job is to make it work between now and then. And hopefully we'll be doing a good enough job that they'll allow us to carry on. I know you mentioned about the wallpaper in this room. I don't know if you looked at the damp part on the top, which is not damp. It was actually Mr. Congreve sent it to Paris to have it restored. So the brown paper on top is European and the paper underneath it is bamboo. And that's just the sign of the way things are different. But other than being told that by a guy called David Skinner, who is the expert on wallpaper in the country, we would never have known. We're still learning things about the gardens. We're still learning things about the Congreves and about, in particular, Mr. Congreve. For any of you that have got a chance to see the audio-visual piece in here, there is a connection to James Bond. Now, I've totally put legs on that connection because it's great for advertising. Totally put legs on it. But that's what you need to do. So it is in this space that we want to do events like that. They used to entertain all sorts of people here over the years, and there was royalty. We used to watch helicopters land on the lawn up there, and we would be told, don't be up around the house today. I've worked here in what feels like an eternity. Tommy was around the same time, which we started here. Now he's gone on to a much better career, I would say, in 1989, which feels like a lifetime ago. And then I left and did other things and came back. And when I came back, I had that feeling, which I hadn't had in a long time, of being welcomed and being part of something. And then because we've been so busy with the work, and I should apologize for the muck on the path because we're not finished yet. And Malua, the guy who drove some of you up, is available to drive you back down again when you're finished. Or if you want to carpool, please do that. So we continue on the work right up until today and then beyond, and we'll keep doing that all work. But it's that feeling that I had when I returned here, with all that work and the destruction and the chaos that had to happen to bring this new Mount Congreve out. We hadn't had that nice, warm feeling here until today. Really, I mean it, until today. So I really appreciate you being here, and thanks for bringing your stories here. Thanks for bringing your inspiration to us. And I'm going to now lead you out this door, out to the front and into the cafe for your afternoon tea. Okay? Thank you very much for coming.